to introduce to you guys Clarke Atkins. He is the Jane Lewis Seeks Distinguished Professor of Companion Animal Medicine Emeritus at North Carolina State University, as well as the Norden Outstanding Teacher Award recipient. Board certified by the ACVIM in both cardiology and medicine, Dr. Atkins has served on 4 ACVIM or International Consensus Committees on systemic hypertension, canine mitral valve disease, and cardiorenal syndrome, as well as received the Honorary Member Award from the American Heartworm Society in 2019. His research involves canine and feline heartworm disease and treatment of cardiovascular disease in dogs, cats, and horses. He has over 150 publications and has provided well over 1,000 hours of continuing education in the U.S. and many countries around the world. During the live Q&A, Dr. Atkins will actually be joined by Dr. Melissa Kaufman, the Pharmaceutical Development Manager here at SIVA. In addition, we're joined by our biostatisticians, Spark Fang and Tomas Blondell.
Dr. Kaufman and I will present these data. The BESST trial compares Cardalis, which is a fixed combination of benazepril and spironolactone, with benazepril itself. And as you can see, this is a clinical study of ACVIM stage C dogs, which is important because this drug has been long appreciated in Europe, but it's never been tested against this severity of heart failure, and nor in this largest study. In addition, this is a pivotal efficacy study for the FDA, and I would like to congratulate Stephen not only on completing this study, but also on achieving that approval. When we talk about spironolactone, we think of mineralocorticoid receptor antagonists, of course, MRAs. So in summary then of the BEST trial, ACVIM stage C, as I mentioned, this was a study carried out in the United States. It's a multi-center, double-blind, randomized, good clinical practices field study, which also was FDA, so it was highly supervised. It's the best kind of study that we can do. 27 centers in the U.S., and it was carried out from 2012 through mid-2016 with a follow-up period of 12 months. The objective was to compare the clinical effectiveness and safety of Cardalis, the fixed dosage benazepril spironolactone combination given once daily versus control population which receive benazepril at the same dosage. The last point I want to make is that 569 dogs were enrolled in this trial. That is the largest veterinary cardiac study done to date. So I'm going to turn it over now for materials and methods to Dr. Kaufman.
Thank you, Dr. Atkins. Okay, so yeah, I'll present the materials and methods briefly here. So inclusion criteria for this study was based off of clinical, radiographic, and echocardiographic parameters. Clinically, the dogs had to have moderate to severe mitral regurgitation. They had to be larger than 2.5 kilograms, have a left-sided grade 3 out of 6 or greater murmur, and have signs of exercise intolerance and or dyspnea. And that had to be within the previous 10 days or at day 0. Exercise intolerance and dyspnea was scored on a scale of 0 to 3. So a score of 1 at day 0 or within the previous 10 days was required. They also had to have heart enlargement and pulmonary edema on thoracic radiographs with evidence of cardiomegaly. The pulmonary edema could be at day 0 or within the prior 10 days. Pulmonary edema was scored on a scale of 0 to 4, and it had to be greater than or equal to 2 within the 10 days before inclusion or at day 0. And finally, they had to have mitral valve disease on the echocardiogram, so typical valve lesions and evidence of moderate to severe mitral regurgitation. They were allowed some previous cardiac treatments prior to enrolling in the study. ACE inhibitors were allowed up to 30 days treatment prior to day 0, and other cardiac drugs were allowed up to 10 days treatment prior to day 0. Mostly the other cardiac drugs were required for stabilization of the heart failure. And you can see some of the ones listed here that were included on the study. The most important probably being the diuretics, largely furosemide. And furosemide was allowed within the 10 days prior to day 0. It was allowed oral and IV, but IV was only allowed for less than a 48-hour duration if needed. And it was mandatory to be receiving oral furosemide at day 0 at a dose less than 6 mg per kg. So we wanted these dogs to be stabilized, but not on long-term cardiac therapy. At day 0, as I already said, they had to have oral furosemide being prescribed. It could be either initiated at day 0 or continued from that 10 days prior. The investigators were allowed to increase or decrease this dose as they saw fit during the study, whether it be for a cough or increased resting respiratory rate, or if the dog had some azotemia. They were allowed to play with this dose as long as it didn't get higher than the 8 mg per kg per day. And if that happened, the dog was withdrawn for the study and considered to have met cardiac endpoint. There were a few cardiac meds that were allowed besides the furosemide, and mostly these were just for heart rate control. So digoxin and calcium channel blockers were allowed on the study. All other heart meds had to be stopped at day 0. If the dogs needed the cardiac meds, they needed to be withdrawn from the study. And finally, at day 0, dogs were tested for heartworm disease and, of course, screened for other heart diseases. And if either of these was present, they were not allowed to start the study. The tested treatments, as Dr. Atkins already mentioned, were the combination Cardalis with benazepril and spironolactone versus benazepril. So this was a positively controlled study. Blinding was ensured by a treatment dispenser, so both the investigator and the client of the dog, or the owner of the dog, did not know what treatment the dogs were receiving. The doses are listed there, and due to the weight range of a dose, there was a range given, and those are in the parentheses underneath. So benazepril was given in a range of 0.25 to 0.5 mg per kg, and spironolactone in a range of 2 to 4 mg per kg. So follow-up visits, we had follow-up visits first at day 7. This was to kind of screen dogs for early failure. And then day 30, day 90, day 180, day 270, and finally at day 360, which is when the primary efficacy criteria was determined, which was the percent of dogs that had met cardiac endpoint. We also looked at a number of secondary efficacy criteria, as well as, of course, adverse events and safety throughout the study period. Some of the secondary efficacy criteria we looked at were the clinical signs present throughout the study versus day 0, the quality of life versus day 0, and this was determined by a fetch score, which is owner completed. So this was the owner assessment of the quality of life. We also determined the percent of the animals that had reached the cardiac endpoint, not only at day 360, but at each visit, as well as the time to reach the cardiac endpoint and the time to cardiac death and euthanasia. And the definition of our endpoint included death due to cardiac disease or euthanasia due to cardiac disease. This includes sudden death. We can't always determine if that's cardiac or not. So for study purposes, it is determined that it will be cardiac. Also recurrence or worsening of pulmonary edema. This is determined on radiographs and the radiographic score. And this is regardless of the current doses of furosemide. Worsening of clinical signs and or new cardiac signs versus day 0 was also a reason to reach endpoint. And this included the need for therapy with the non-authorized cardiac drugs we discussed, and also the increase over the 8 mg per kg furosemide. And finally, if a dog presented with new cardiogenic ascites, that was also a reason to reach cardiac endpoint. So for now, I will turn it back over to Dr. Atkins to talk about the study population and the results.
Thanks, Melissa. The results I will follow here. Enrollment and efficacy population. I told you when this study was carried on, 27 centers, which are shown for you in the map. These were carried out by ACBIM diplomats, either cardiology mainly or internal medicine, 2 of the participants. The safety population, 69 dogs. The efficacy population was 414 dogs. These are started out with 569 dogs, and this was the safety population. So regardless of whether these dogs completed more than a week of the study, they were included in the safety population. There were, however, some exclusions from the study, 68 from Cardalis, and as you can see, 87 from the benazepril group. And that difference was of interest to me. That gave us 414 dogs in the efficacy population. So that's what we're using for all of the, the primary endpoint, for example, and some of the secondary endpoints. There were, however, an additional 16 dogs in each group that were taken out by the FDA because as the medical records were perused, there were dogs in which the dosage went over 8 mg per kg for Lasix at some point. This was largely due to changes in body weight, owner error, veterinarian error, or a phone call in the middle of the night in which the dosage was increased until morning, the dog was okay, and they went on. The FDA felt that this did not affect the efficacy of the drug, but did not want to use it for the time to event population. So that reduced that to 382. Now, I promised you we would talk about why there was so many exclusions and why they were different between the groups. And the reasons are shown for you here. Lack of compliance, non-cardiac disease adverse events, dosing documentation failure, exclusion of the whole site, owner request, non-cardiac death or euthanasia, and late discovery of exclusion criteria. It turns out that those are all small individually and are the same between groups, number of dogs. The difference between the groups came in one category, and that was heart failure before day 7. So early recurrence of heart failure. These dogs were stabilized, and if they went back into failure in the first 7 days, they were excluded from the study. So if we look at these graphs and we exclude everybody else, what we see, 42% exclusions in the benazepril group versus 28%. And if we equalize those, we find then that there were 14% exclusions greater in the benazepril group. That may just be an explanation for the exclusions, and there is no more, but we wondered, could this possibly signify an endpoint difference? Was early onset heart failure different between the groups? And we'll come back to that in results. Gender between studies was approximately equal, males slightly overrepresented, 90% were neutered or spayed, 44 breeds, including 25% mixed breeds, and the Cavalier King Charles Spaniel and some other breeds, but notably Cavaliers were about 10%, which is a nice number. These were equally distributed between study groups. The age was a good targeted age, a mean of 11 years of age, with a range up to 19, and the majority, 2/3, were over 10 years of age. Body weight, as you'd expect, was an average of 20 pounds or 8.6 kilos, and the vast majority were under 25 pounds. So I'm going to run through the characteristics of the populations relatively quickly. And what we see here is a group of things, some of which I've mentioned, but you can see that the numbers are basically identical for age, body weight, gender, breed distribution, and severity of cardiac disease. 95% of the dogs were ISAC 1B or 2, and 100% of the dogs were in ACVIM stage C. What about their scoring? The clinical scores and pulmonary edema scores were virtually identical. So that includes clinical scores, appetite, cough, dyspnea, exercise intolerance, and syncope. And the reason that some of them had a pulmonary edema score of 1 or had no edema is because they were cleared during that first 10 days of pre-entry treatment. The treatments are shown for you here. I just want to point out about pimobendan here. Pimobendan was given with ACE inhibitors. It was given with ACE inhibitors and spironolactone. It was given alone, and it was given with it was never given with just spironolactone. But you can see that these numbers are basically identical between groups, so no difference there. FET score, median FET score at entry was virtually identical, as were radiographic, echocardiographic, ECG parameters, serum chemistries, and notably creatinine, BUN, and potassium levels were identical between the groups, as was the urinalysis. So no differences statistically or by observation here. So as someone who was involved in this early on, it's gratifying to see that the randomization turned out so well. The target population was well represented by the study population, and there was equality between the two groups being tested. Males were slightly greater than females. They were 10-year-old dogs, approximately small breed, and in ACVIM stage C. None were refractory or stage D. Okay, so what about the efficacy results? This is where I think we will have the most interest. The number of dogs reaching the cardiac endpoint was our primary endpoint. Secondary endpoints were number of dogs reaching the cardiac endpoint by visit, the time to the cardiac endpoint, and time to cardiac death or euthanasia. Some things that did not appear in the Freedom of Information Act, because we added these analyses later, and you should know they were not in the original design, were the number of dogs with heart failure recurrence in the first 7 days, the proportion of dogs dying or which were euthanized for cardiac disease progression, and time to all-cause withdrawal from the study. So here is the major point of this presentation, I guess, and this is the primary endpoint, the number of dogs reaching that endpoint at day 360. Of 414 dogs, you can see that only 78 of the Cardalis dogs reached the endpoint, where 86% of the control group reached the endpoint, with a p-value of 0.0325. I chose to show this to you in a slightly different way. This shows you the percentage of dogs surviving to the end of the study without being removed. So they didn't have recurrence of failure, they didn't die. And you can see that there's a fairly dramatic difference here. This is about a 40% difference at 1 year when we compare it this way, sort of a glass half full look at things. And so all of this benefit is accrued by treatment with Cardalis in terms of the endpoint at day 360. Another important endpoint, a secondary endpoint, number one, is the number reaching that endpoint by study date. And we can see then that at baseline, there's no difference between Cardalis in orange, benazepril in gray, with a p-value that's not significant. But after that point, starting at day 90, it remains significant, as can be seen by the asterisks over the gray bars of the benazepril group. So what I want to emphasize is that this occurred early, within the first 90 days, and it persisted throughout the study, this benefit. I'd also just like to emphasize something that I'll show you in the next slide, is that that benefit did not occur at 90 days, but somewhere between. And you'll see that it looks as though it occurred much closer to 30 days than it did to 90 days. And I think that's really important. I think it argues for getting dogs on Cardalis early in the disease course. That's something I've argued for years. The benefits are early, and we should not delay instituting the drug. So looking at the endpoint number 2 as a secondary endpoint, how long did it take him to reach it? And what we see here is that the difference was between the groups was 103 versus 73, or a difference of 30 days. This is statistically significant, highly significant difference. And what I want to point out here is a couple of extra things. One is that at day 25, there is no difference between the group. And probably not at day 30 either. There certainly wasn't significant. But when you get out to day 50, these groups have started to separate really nicely. I don't know that it's significant at day 50, that wasn't analyzed, but it is clearly separating. And this tells me that this separation occurs early. By day 90, we know that it was statistically significant. The last thing I want to show you from this graph is something I try to emphasize every time I look at a Kaplan-Meier curve, and that's that if we evaluate that curve up here at the 87th percentile, there's clearly no benefit. So if we want to know if there's a benefit that saves lives in the first week, we can't say that's true. If we drop down to the 50th percentile, we know that it's statistically significant, and this is what we're used to looking at. When we look at survival curves, we look at the curve, we take one number away, and we talk about that. And that's probably the right thing to do. But there is a subtlety, and that's that if we look at the 25th percentile, as is shown for you here, and what you see is when you use the 25th percentile, the difference between the control group and the treatment group is now 6 months. So for 25% of the dogs entering this study, they have a 6 months benefit in reaching the endpoint. That's substantial in the life of an 11-year-old dog with heart failure. And that's not just for this study, that's for any study. And then the time to that endpoint was affected by a number of things, but I want to point out that the odds ratio for treatment, Cardalis versus benazepril, reduced rate by 0.71, or there was a 29% reduction in risk of dying or worsening heart failure in the first 360 days. BUN negatively affected this. FETCH score negatively affected this. Atrial and ventricular dimensions negatively affected this, as did the furosemide dosage at entry. Gender had a sparing effect, with females being better off. And the third secondary endpoint is time to cardiac death or euthanasia, and we see that there was a statistically significant benefit here, and that the risk of dying for cardiac disease is reduced by half if they are on Cardalis, as opposed to benazepril alone plus standard therapy. The post-hoc endpoints that most interested me was this early heart failure recurrence. So despite us showing that there is no benefit early on, remember that dogs who went out in the first 7 days were not considered in the analysis of survival or time to endpoints, etc. So of 569 dogs, almost twice as many dogs were, as a percentage, on benazepril went out due to heart failure recurrence in the first 7 days. This was statistically significant, even though numbers are small. And we see here then that Cardalis versus benazepril has a pretty dramatic effect on the return to heart failure in the first 7 days. And then lastly, time to all-cause withdrawal. And what we see here is that there was a pretty highly significant difference between groups, with Cardalis having fewer withdrawals, and we see that all causes BUN elevation, heart rate, left atrium to aortic ratio, left ventricular dimension, chloride levels, vertebral heart scores, and furosemide, all of which were significant and contributed to this as a reason for withdrawal. Not worse in the Cardalis group for sure, in fact, better. So the safety then, obviously important in a study like this, particular emphasis to renal function and potassium levels. And the adverse event and serious adverse event as defined by the FDA, and I'm not saying it isn't appropriate, but they're not the way that we would define them as clinicians. So their definition is any observation unfavorable and unintended occurring after the use of a veterinary product or investigational veterinary product, whether or not it's considered to be product related. This is an adverse event. Serious adverse event is a fatal, life-threatening, or one that requires professional intervention, again, associated with the product, but not necessarily caused by the product. So this shows you a summary. I don't want to spend a lot of time here, but I want to just point out that as adjudged by the FDA and the scientists at SEBA, dogs that had at least one treatment-related adverse event was pretty small, 45 out of 559 in the Cardalis group versus 34. Certainly not different significantly. And then serious events, pretty common in these old dogs. Serious events occurred, but those that were thought to be treatment-related were surprisingly small and identical between groups. I think that point is worth mentioning. It speaks to the safety of both RAS suppressant therapy overall, and in particular for our efforts today, Cardalis. And then death or euthanasia due to treatment-related events was virtually 0, 1 and 2 out of 559. So no significant differences between groups. Important. Looking at the adverse events, we'll look at the percentages here. We show you in orange and in gray for the benazepril group. And we see that there were no differences. In fact, these are almost identical. The one statistically significant difference is vomiting, more frequent with Cardalis. Dyspnea, anorexia, cough, vomiting, exercise intolerance, lethargy, and diarrhea were virtually identical with the exception of vomiting. These are the top 7 most reported adverse events. They're typical of signs associated with heart failure and older dogs. So aging cardiac patients, there's nothing of surprise here. So one of the things that you're most interested in was serum potassium levels. And we would expect that the addition of an MRA, be it spironolactone or eplerenone, would cause higher potassium levels. This is a box and whiskers graph that you're used to, with median shown by the line. The boxes show the 75th and 25th quartiles, and then the range is shown with the whiskers. The normal range is shown for you for each of these graphs over to the right and by the dashed lines. So the median levels are identical, even a little higher than at day 90 for Cardalis. Medians never go out of the normal range, never come close to going out of the range. And then sometimes it's actually lower, and again higher at day 360. Renal function would be the other thing you'd be interested in. And you can see, looking at the box and whiskers graph, that there are tons of azotemic dogs early on. They remain throughout the whole study. And you can see, however, that the BUN never rises above the normal range based on the median. And it is oftentimes virtually equal, although it does rise in the Cardalis group at day 360. If you look at creatinine, which is a little more reliable, although certainly imperfect, we see that, again, the medians never go above the reference range here of creatinine. And the only significant finding in all the renal evaluations was that serum creatinine was significantly lower at day 90 in the Cardalis group. And then it was higher again at day 360. So again, this is pretty gratifying. As always, renal function should be watched in heart failure patients, particularly if they're on high doses of Lasix, particularly if they are on RAS suppressant drugs. So our safety summary is that 5 of the top 7 adverse events were expected in aging dogs with heart failure: lethargy, cough, anorexia, dyspnea, exercise intolerance, and were baseline characteristics of the population at day 0, meaning they were pre-existing abnormalities. Vomiting and diarrhea were the top 2, and these are commonly seen with the administration of oral drugs in all studies. There was no significant difference between groups in occurrence of adverse events or serious adverse events. And that's really saying something, and it backs up, or is backed up, by the pharmacovigilance data from Europe, after 76.5 million doses have been prescribed, adverse events reports are really rare, 0.01%, or 1 in 1,000 to 1 in 10,000. So we can conclude, and this is what's on the Freedom of Information Act, is that Cardalis is safe and effective when used with concurrent therapy, in this case diuretic, for the management of clinical signs of mild, moderate, or severe heart failure in dogs due to left-sided valvular disease. And I would just add my own personal editorial comment to that. It's not just management of the clinical signs, because RAS suppression has very positive effects on remodeling, and which can contribute to improved survival. So discussion, brief, but if we look at all the endpoints, we see that the primary endpoint was met nicely with Cardalis. The percentage reaching the primary endpoint by visit occurred persistently and early. The time to the cardiac endpoint was prolonged significantly, particularly so for the last 25% of the dogs remaining in the study. The baseline population with early heart failure recurrence was significantly greater in the vonaprazan group. The percent death, cardiac death, was greater but did not reach significance in the vonaprazan group. However, when you looked at all causes of heart failure, meaning euthanasia and death versus sudden cardiac death, it was significantly greater. And then we have time to cardiac death or euthanasia took significantly longer. So a nice group of signs, very gratifying to see. The conclusion then, Cardalis is superior to vonaprazan alone, along with standard therapy, with significantly fewer dogs reaching the end. Cardalis delays the time to cardiac endpoint, including cardiac death, as compared to vonaprazan without spironolactone. Cardalis is well tolerated. Most of the adverse events are those that are expected with an aging population with heart failure. And the post-market data in Europe show that adverse events are exceedingly rare. Thank you all very much.